My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. So welcome to Operate with Zen. We have the pleasure today of talking with Dr. Patrick C. Walsh, who is the University Distinguished Service Professor Emeritus of the James Buchanan Brady Urological Institute at the Johns Hopkins Hospital. He's one of my great mentors and educators throughout my training and my life, and it's an absolute pleasure today to be talking to Dr. Walsh. We're going to talk about a number of topics. We're going to talk about purpose. We're going to talk about mentors and mentoring. We're going to be talking about an evolution of life and goals. So we'll start this way, Dr. Walsh. Tell me about your early years and how they influenced your life.
So Phil, it's great being with you. So I'll introduce Phil. Phil is one of my great residents and subsequent faculty members. He's a great guy, a brilliant surgeon, and I've enjoyed all the years I've known you. Well, I was lucky to be brought up in a religious family and received my education from preschool through high school from Dominican nuns. There, every day, we were reminded why we were on this earth: to know, love, and serve God, and to share the gifts that we were given with our fellow man. I always wanted to be a doctor. Let me start over.
Yeah, sure.
Sorry. I was lucky to be brought up in a religious family and received my education from preschool through high school from Dominican nuns. Every day we were reminded why we were on this earth: to know, love, and serve God, and to share the gifts we were given with our fellow man. From the time I was a little boy, I always wanted to be a doctor, and the pathway for my future seemed very clear and relatively uncomplicated. For these reasons, I never seemed to lose my way. And when the future was unclear, all I did was ask for God's help.
That's great. And so you talked about some of your early schooling beyond high school then. Tell us about your training and your mentorship in medicine. Who are your mentors? How did they influence you?
We were not wealthy. My father owned a little cigar store and we didn't have much money. But I was fortunate to receive a full tuition scholarship for my undergraduate education at Case Western Reserve, and to go there to medical school with funding from the Akron Beacon Journal Knight Foundation. I have to stop there because that phone is making noise. We were not wealthy, and my father owned, we were not wealthy. My father owned a little cigar store and we didn't have much money, but I received a full tuition scholarship to Case Western Reserve for undergraduate school and funding from the Knight Foundation of the Akron Beacon Journal to go there to medical school. In undergraduate school, I came under the influence of the Professor of Embryology. He was really a tough guy. If you didn't do well in that course, you just didn't go to medical school. However, he had an expression which has stayed with me my entire life. You are not here to make friends. Rather, you are here to find the truth. And I may have overdone that many times in my life, but I have always lived that philosophy. In medical school, I worked closely with Claude Beck, an innovative cardiac surgeon, and went off to Boston to spend 2 years in adult surgery at the Peter Ben Brigham Hospital and 1 year of residency in pediatric surgery at the Boston Children's. This was a very exciting environment. Cadaveric renal transplants had just begun a couple of years before I arrived at the Brigham in 1964, and valvular replacement for rheumatic heart disease was in its infancy. I actually spent 7 months in adult and pediatric cardiac surgery, and this prepared me well for performing thoracoabdominal operations as a urologist. Although I had many mentors during those years, like Robert Gross, one of the founders of pediatric surgery, and Joseph Murray, the Nobel Prize winner for transplantation, the person who most influenced my future career was Francis Moore, the Moseley Professor of Surgery. In the fall of 1965, at age 27, I went to see Dr. Moore for advice about where I should train in urology. His advice shocked me. He told me I should go to UCLA and train with Willard Goodwin, spend a couple of years of research, and then return to the Brigham to be Hartwell Harrison's successor as chief of urology and the Elliott Carr Cutler professor. I tell you this story because I had no idea that I could ever reach such heights. But having been told by Dr. Moore that I could, I realized that I had to live up to that promise. And as a result, when I see young people who have great talent, I also tell them about what kind of future they may have, so they will realize their true potential. At UCLA, I trained with Willard Goodwin, who pioneered the use of intestinal segments in reconstruction of the urinary tract, performed the first percutaneous nephrostomy, and I believe was the first person ever to use prednisone for rejection in renal transplants. Joe Kaufman, a brilliant surgeon, was also there and helped me to fine-tune my surgical technique and develop expertise in renal vascular surgery, something I continued to pursue when I first came to Hopkins. Ben Gittis was also there as a young faculty member and a role model. He was brilliant, charismatic, an excellent surgeon, and probably the brightest urologist in our field at that time. Following residency at UCLA, the US was still involved in Vietnam, so I was required to spend the next 2 years at the San Diego Naval Hospital. It was there where I had my first exposure to radical retropubic prostatectomy. As a resident, we only used the perineal approach, which Goodwin learned as a resident at Hopkins. While in San Diego, I was offered the position to be the chair at Hopkins, but explained that I had arranged to spend a year in Dallas, Texas with Gene Wilson, the scientist who discovered dihydrotestosterone, and could not come to Hopkins before 1974. They agreed to wait. That was a fantastic decision for everyone, because during that year, we discovered the 5-alpha reductase deficiency syndrome and induced experimental BPH in dogs using androgens plus estrogens. In 1974, we arrived in Baltimore.
Wow, that's really exciting. I think one of the greatest things, I don't know if I've ever heard you say this before, but how Dr. Moore gave you the inspiration and told you you could reach heights that you didn't know you could. And I can say firsthand, you have inspired quite a few of us by passing that along. So that's a great insight. And I think for all of us, as we think about mentoring young people, that's a really great insight to inspire them and tell them that they can do great things. And I thank you for that.
Yeah.
If I could diverge for one other moment, just when we think about mentors, what advice would you give now to young people coming up when seeking out mentors?
Hmm. I don't know the answer to. I mean, the people you admire. I mean, that's what I did. I had all these people I admired, and I sought them out and talked to them, and most were receptive. Maybe some weren't, but I think that's the important point. I'm always looking at it from the other side as being a mentor. Who do I seek out? But that's a very good question, Phil.
Yeah, well, that's great. So now we're going to go a little further into your history. So you're getting ready for your first job at the Brady. Tell us about that transition, what prepared you for that job, and then how things proceed from there.
Okay, so with all that background, in 1974, we arrived in Baltimore. So I came to Hopkins rather than the Brigham because I really felt that my goal in life was discovery. And that seemed to be an imperative at Hopkins, a heritage of excellence. And shortly after I arrived, I learned a lot of things, but one of them was that radical prostatectomies were rarely performed even at the institution where the operation was pioneered 70 years earlier. Why? Well, all men were impotent, 25% had no urinary control, and patients felt that the treatment was worse than the disease. And urologists were frightened by the life-threatening bleeding and didn't want to operate. So at that time, I wondered why these side effects occurred and whether they could be prevented. Having been all around the country, as I've described, I had never heard anyone raise that possibility. So what I decided is that I would try to figure that out. And having had the experience in San Diego about the blood loss at surgery, I decided I would tackle that first. I mean, it was amazing, all the different places when a cystectomy was done. The dorsal, and the mistake was the dorsal vein was transected immediately adjacent to the pelvic floor, and it retracted. So there was no way to stop bleeding. And it was like a fire hydrant. And no one ever said a thing. It was like it was raining outside, and no one even talked about how you could stop it. So that was my first challenge. And so I said, well, to Bill Reiner, who was a resident, I said, well, we'll go over to Walsh and Xerox the anatomy of the dorsal vein. And he said, there isn't anything. Well, that turned out to be true. And we didn't know where the nerves were either. And we knew men were impotent, but why? And what we didn't know is that the sphincter also was not where we thought it was. So why were we so ignorant? Because of using the adult cadaver. Using the adult cadaver, shortly after death, the abdominal contents compress the pelvic organs into a thick pancake of tissue, and formalin dissects away the tissue planes. So you can't find anything there. So what did I decide to do? I decided to use the operating room as an anatomy laboratory. And so in doing cystectomies and the few radical prostatectomies I did, I would dissect everything out. And I realized there was a common trunk over the urethra. I learned how to ligate it and transect it with very little blood loss. And shortly thereafter, in 1977, a patient came back and told me he was fully potent. So I knew from that one patient, an N of 1, that the nerves did not run through the prostate. Everyone believed they did because everyone was impotent. Well, in this patient, I clearly took out his whole prostate. So where were the nerves? So we looked everywhere we could. And so like I referred to a little earlier, I just said to God, open my eyes. And about 8 weeks later, we went to our first meeting of the American Association of GU Surgeons. And the first night, there was no social event. And my wife and I went to a restaurant downtown. And as we were approaching the table, I saw an old man standing by himself behind the maitre d' who looked lonely. And for the only time in my life, I went up to a total stranger and asked him if he had anyone to have dinner with and would he like to join us. He said, that would be lovely. I said, what's your name? He said, my name is Peter Donker. I said, what are you doing in town? He said, I'm attending the American Association of GU Surgeons. So he was at the same meeting, and the concierge had told him to go to the same restaurant we went to. So we had a very nice dinner. At the end of that dinner, I thought that was the end of the story. But 4 years later, 4,000 miles away, we meet again. He was retired, and his successor invited me to spend 5 days lecturing, operating, visiting laboratories. And on the fifth day, February 13th, 1981, a very easy date to remember because it was my 43rd birthday, my host said, you know, Dr. Donker would like to repay the favor. He'd like to take you to see the Windmill Museum. So when I saw him, I said, what are you doing these days now that you're retired? He said, I'm working in the anatomy laboratory. And without any premonition of what I was going to see, I said, well, I'd like to go there instead. So he takes out an infant cadaver, a dissecting microscope in his drawings. And I said, what are you doing? I'm dissecting out the nerves to the bladder. I said, why? It's never been done before. Why? Well, I just told the story why we were so ignorant about this. And I said, where are the branches to the corpora cavernosa? He said, I've never looked. And 3 hours later, there they were outside the prostate. Well, fantastic day. But the next challenge was, how do you find these microscopic nerves in the adult male pelvis? Well, I did not, this was February. I did not do another radical prostatectomy until October. And at that operation, which I have the drawings for, I saw vessels that ran in the exact location as the nerves ran in the infant cadaver. And I speculated that this could be the neurovascular bundle that I could use as the macroscopic landmark. And so I now had to wait till April 26, 1982, when I operated on a 53-year-old professor from Cleveland, Ohio. And he is cancer-free and lived a full life, potent and continent. So that was a very exciting, experience in my life. And the 40th anniversary of that operation will be coming up next April. Well, the next challenge was to perfect the technique. I developed a database. And, you know, I've always believed that if you have been given the privilege to sail in uncharted waters, you have the responsibilities to make those charts. And so I had, you know, the preoperative findings, the intraoperative procedure, the pathology, and then as years went by, changes in operative technique. And I spoke to every single patient I operated on every 3 months for the first year and longer if they had not fully recovered. I operated on 4,569 men. And if you do the math, that's about 20,000 telephone conversations. And what I did is I was able to operate, and every operation looked like it was a Xeroxed copy. But what bothered me is I could operate on a 250-year-old man the same day and do what looked like the same operation. And one patient was perfect immediately, and the next one took a year or longer. So in the mid-1990s, I got an excellent video camera, and I started videotaping my cases. And then I went ahead and purposely took 66 patients, operated on them, videotaped them, and did third-party quality of life outcomes done by an independent person. And at 18 months, with all of that information, I went back and reviewed all of those videos frame by frame. And I think that this is the first time anyone at an open operation ever did that. You know, we've done it in sports for many years. And I was able to discern about 4 different things that you could not see. When you operate, you're looking at the tips of your fingers. When you're watching yourself operate, you see a lot of peripheral things that are going on that begin to make sense. So my goal was to make every patient potent and continent at 3 months. And over 29 years, I made 28 major changes. And I stopped operating in June 2011, having performed 4,569 operations. And although I never achieved my goal, but in the patients I operated on in the last 2 years using all of these improvements, in men who were fully potent preoperatively, at 3 months, 50% were potent, and at 18 months, 93%. At 3 months, 80% of patients were totally dry, and at 18 months, 95%. And in the long run, only 2% wore a pad. that they changed more once a day. So that's the way I perfected that operation.
It's really incredible. You know, I've heard versions of that story, but you learn something new and you take different things away every time you hear it. So thank you for sharing. And I also want to share, I think during my residency, I tallied them up. I did right around 200 radical prostatectomies where I was your assistant. And every single one of those was a joy, but I was also in the operating room at your last case. And it is one of the most poignant memories of my training and of my career. And I just want to share with our audience a few of the things that I've taken away with you that you may not have totally verbalized today, but you did. And one was you took the same approach to the operation every day, from the way you set up the drapes to make the incision and proceeded through the operation, obviously accounting for anatomic variance and not. But what that instilled in me was that when things didn't feel right, there was something different going on, right? It created a visceral sense that something was abnormal and you had to readjust your thinking to what was different about this patient or what was different about that case. One of the second things was, you know, you talked about talking to your patients, you know, all of the 20,000 phone calls, and surgeons get really caught up in the operating room because that's a lot of our primary focus. But there's so much of our relationship that is with those patients, and so much of the therapeutic relationship happens outside of the operating room. And you really instilled that in me. And I think a lot of the trainees that you influence is that being involved in your patients' lives outside of the operating room is just as important, if not more important, than what happens in those few hours with them in that special setting. And the last thing I want to point out, which I've heard you say before, but really came out poignant to me today, was that when you looked at the videos and you caught in the peripheral view, right? We're so laser focused when we're operating that when you were able to look at the videos, you were able to step back and take in kind of a more global view of what was going on in the operation. And I'll tell you, in my surgical training, sometimes doing some really challenging cases, when I'm struggling, I purposely try and step back and take a more global view of the operation and of the field to see if there's something else I'm missing that could make that operation better. So I thank you for those insights.
Well, I really enjoyed, so everyone should know that my first assistant on all those cases was my first year resident. And as a first year resident, you would do 100 or more cases with me. And I did that because my promise to the patient was that I would do their operation. But, and you can comment on this when I'm finished saying it, but having my first assistant be a first year resident, at the end of their 6 months doing that with me, he only had 2 residents a year. They knew that operation. There was only 2 people that knew that operation. One person knew that operation as well as me, and that was that for that person. And so you could then go operate with everybody else, and they would say, "What's Walsh doing now?" So it was a wonderful system. The patients got the best operation. It was a time of total concentration. You would hear me share ideas about what I'm thinking, and it was. I think it was fun for me and fun for you.
It certainly was. I can verify that. So you've kind of talked about purpose and a purpose of discovery. Tell us now, as your career has evolved, has your purpose evolved?
Okay, over the years, I had many friends who were smarter, better educated, more talented, possibly worked harder. However, many of them failed to make a major impact in life because they kept shifting their goals, never maintaining a long-term focus. For a while, it would be academics, then eat, drink, and be merry, then physical training or some other distraction. Each time they lost focus on their long-term goal and were not able to really fulfill their potential. I was fortunate to have been able to maintain my focus all of those years. I felt my #1 job as chair was training the leaders of the future. And my passion was and still is discovery. Discovery in the laboratory, in the clinic, or in the operating room. And although I no longer operate or run a department, I am still dedicated to my patients and continue to see patients in clinic with medical students, teaching them that the secret in the care of the patient is caring for the patient. And I'm still very involved with our genetic research on prostate cancer.
It's wonderful. And as I've evolved a little bit, I've got more into, we'll call it spiritualness or mindfulness. And one of the concepts is a concept of dharma, where talent meets purpose, meets enjoyment, meets service to people. And you truly embody that with your career and your contributions to our field and to our patients. And I think that's an incredible contribution and a shining example of what we all should aim for. I wanted to give you an opportunity if you had any questions or anything else you wanted to talk about. And then I wanted to just kind of summarize some of the really salient points that I wrote down and noted as we talked today.
Well, I have a backstory to the discovery of the neurovascular bundles. The mentor I didn't talk about was my Uncle Harry. And if I get a little teary-eyed when I tell this story, you'll see why. So when I was a little boy, we were poor and we didn't have a lot of things. And I had an Uncle Harry who went for a couple of years to Carnegie Tech and then came back to Akron to run his father's plumbing business. So Uncle Harry would rather be out in nature rather than underneath a sink. And when I was about 8 years old, he saw that I had this same interest. So Uncle Harry and I would go on hikes every Sunday, and we would catch turtles and snakes and find arrowheads and fossils, build transmitters. One summer, we went with a Geiger counter to Canada to hunt for uranium. And Uncle Harry would teach me big words like super heterodyne. So when I was about 8 years old, Uncle Harry taught me the word, the auricular ventricular bundle of His. Now, this was an alliteration, but why he taught me that, I have no idea. So after these hikes, we would go home, and Aunt Anna, my mother's older sister, who was a nurse, would make dinner. And it gave me a chance to talk about medicine to someone. So that night, I looked in her nurse's dictionary, and I saw that the auricular ventricular bundle of His was the neuromuscular bundle between the auricle and the ventricle. So from the time I was 8 years old, I had this visual impression that autonomic nerves ran in association with adjacent structures. So on that day in October 1981, when I saw those vessels, I immediately thought about Uncle Harry and about the what I learned, and that's what helped me with that association. Well, when I was a resident at UCLA, just about finishing my training, had already decided to really focus on prostate cancer, Uncle Harry died from metastatic prostate cancer with Aunt Anna at his side. So today, if you go to Stedman's Medical Dictionary and you look under B for bundle, in the left-hand column, you will see the atrioventricular bundle of His. And next to it, in the right-hand column, you will see the neurovascular bundle of Walsh. Now, how did all that happen? I would never have made my discovery if I had not invited an old man who I didn't know to dinner. If I hadn't met him 4 years later, 4,000 miles away. If I had agreed to go to the Windmill Museum and not gone to the laboratory. And if I had not known about the association of autonomic nerves with adjacent structures. So how did all of that happen? Well, if you ask Yogi Berra would say that's too much of a coincidence to be coincidental. If you ask Einstein would say that coincidence is God's way of remaining anonymous. And if you ask John Paul II, he would say that in divine providence, nothing is a coincidence. And that's what I believe. So I tell young people, listen to your patients. If they tell you something like, they're potent and they shouldn't be, listen to it, see what you can do to figure that out. And if you have any problems, just ask God for help.
That's wonderful, Dr. Walsh. And if you wouldn't mind asking me asking, I know you believe strongly in service and taking care of your fellow people. And I know you spent some time outside of the hospital caring for people and serving the community as well. Would you feel comfortable talking about some of that?
Sure. So you're talking about prison ministry. So about a mile and a half from Hopkins is an enormous prison complex with about 8,000 prisoners in it. And when you're driving home to the better part of Baltimore, the North County, where you and I both live, you have to drive past or through, actually, you drive literally through this prison complex. And on one side, there's a very foreboding wall that actually goes back to 1800. And on rainy, cold nights, waiting for the traffic light to change so we can get in the freeway, you can sit there for quite a while. So there is, in the New Testament, Matthew describes a sermon that Jesus gave just before he was crucified. And he talks about the end of the world and bringing everyone, the Almighty will bring everyone together, and he'll put the sheep on the right and the goats on the left. And he'll turn to the sheep on the right and he will say, welcome to eternal happiness. When I was hungry, you gave me food. When I was thirsty, you gave me drink. When I was naked, you clothed me. When I had nowhere to live, you sheltered me. When I was sick, you visited me. When I was sick, you took care of me. And when I was in prison, you visited me. Then he turns to the goats on the left. And he repeats all of that by saying, when I was sick, you didn't feed me. And to the point where, when I was hungry, you didn't feed me. When I was thirsty, you didn't give me anything. When I was in prison, you didn't visit me. And you are condemned to eternal damnation. Well, I would sit in my car and think about that. And as Jesus said to me, why didn't you visit me today in prison? I would say, well, you were sick and I took care of you. But after I stopped operating, I realized that what was I going to say when I faced Jesus and he asked me when I was in prison, why didn't you visit me? I was just, why didn't you pull over to the curb, Pat, and go in? So it turned out it wasn't that easy to do, but I decided that I really had to do that. And it's been a great thing to do. On Tuesday nights, I visit people in a federal penitentiary who are awaiting trial and sentencing for federal crimes. These are people who never had a mentor. Their parents died of AIDS or were killed on the streets. They never had an education. And now that they're facing long prison sentences in a federal system, if you're charged with a crime, 99% of the time you are convicted on the first trial. And there are federal guidelines for sentencing, and there is no parole in the federal system. And so these people these are people who requested a religious visit, and they realized that the only person they had left was God. And it's so interesting for these people to look at you. And of course, is in my belief, I'm looking at Jesus. Where were you when I was in prison? And they look at me and wonder, why is this total stranger come in here to help me tonight? So it's amazing. And in an hour or 30 minutes, you can make such a difference in their lives.
It's incredible how you continue to impact people on big scales and little scales. It's really impressive, and you continue to grow as a mentor and idol in my eyes. I'd like to end on one note that's a little bit lighter that people may not know about you, but you are a wonderful joke teller. And I will not ask you to tell any jokes.
Well, I'll tell a joke. I'll tell a joke if you want. So go ahead.
Yeah, but I was just say, tell us about the role of jokes and how you used jokes with your trainees, with your staff, with your patients, and really how that helped with relationships.
And the illness is that when you hear jokes, they just automatically are filed in your brain under keywords. And so when you hear a keyword, it just comes out and opens up a folder sometime where there are a bunch of jokes in there. And so it's sort of an automatic thing. Now, one of the ways I think it helped is that you know, when you're the boss, you've got to be sort of tough. But if you can soften things with a little bit of a joke, I always felt that that helped. But to be honest with you, I have no control over it. So I do it with patients and I do it with everybody. So you wanted a joke. The joke that jumps to mind after, and again, this is a perfect example of it because we've been talking about when I faced Jesus. So apparently St. Peter's up there one day and all these people are lined up and he sees a guy laughing. And he thinks, well, I've never seen that before. So eventually by the time he gets up to him, he said, what are you laughing about? I said, this is eternity. You're going to decide whether you're going to go to heaven or hell. I'll get back in line and shape up. So he watches this poor guy and he's doing pretty well. But every time he looks down on earth, he starts to laugh. So St. Peter says, what's so funny down there? He said, you know, St. Peter, down there on earth, they're still operating on me.
Excellent. Excellent.
Yeah.
Well, good. So I'm just going to summarize some of the really important points I wrote down and we'll sign off. You know, I think from the beginning, I think the relationship between God and your faith, as well as seeking truth, really drove you to find purpose and really helped you find that purpose throughout your life. And anytime that you wavered from that and you saw other people waver, it gave you a foundation to come back to and to reorient yourself. One of the great points I wrote down and starred 3 times was how you told your mentees about their future and the great things they can do and how you actively inspired people you knew could do great things. A career and a purpose in discovery and the heritage of excellence you talk about at Hopkins, you certainly not only participated in that, but furthered it. I think your intentional approach with patients and with the operating room is a shining example for trainees. I think we see too many people now trying to learn by osmosis, right? Just kind of be around people, but you can really take an active role and you take notes and you take notice of what's going on. You're present in the moment with your patients and with that operation. But at the same time, be able to step back and take the peripheral view, not only what's going on in the operating room, but what's going on in life, what's going on in the field, what's going on with others around you. Being able to be laser focused, but take it all in around you, I think are all incredibly powerful lessons that I've taken from you.
Phil, thank you for this opportunity. I'm so proud of you and congratulations on your new appointment. We're going to miss you, but let's hope that we can keep communicating like this.
Well, thank you so much. And I'd like to thank the audience for listening and we'll talk to you again soon. Take care.